Welcome back to Tumor Board with Hilario and Aneesh. If you haven't figured out already, I'm your co-host Aneesh.
And I'm Hilario.
Today we are going to dive deep on the clinical years of medical school. So all about rotations, going in the hospital. So to start us off, Hilario, how did you feel that you were finally going to finish your preclinical years and all that time in the library studying and finally start working in the hospital and see actual patients?
Right. Yeah, I think that's, the whole point of medical school, right? Is that eventually you get to be in the hospital and actually play doctor, right? But I do think the feelings, after doing the first 2 years, going into the hospital for your clinical years was mixed, because on one hand you're excited to be finally like wearing your white coat in the hospital and people identify you as a physician or some kind of like medical student, but at the same time you realize that this is going to be very intimidating, right? You don't know what you don't know. It's one of the classic like feeling that you have when you're a med student getting into the hospital, right? And in a lot of ways, I think, we can get into how you can be prepared to go into the hospital in terms of how you present patients and what you need to know before you start every rotation. But there's a lot of ways that you cannot prepare for that feeling. And for me, it was just like a whole combination of, excitement and fear at the same time.
Mm-hmm.
I did spend some time in the hospital actually in my second year with my mentor, the ENT physician that I mentioned in the prior episode. And I spent most of that time in the operating room, on a head and neck surgery, right? And I just remember, the operating room being so cold, and I wasn't very I wasn't very excited coming out of it. I liked the surgery, but I felt like the environment was very high stressed environment, and everybody was kind of like a little bit frantic in the operating room. And I was like, in my head I was like, can we slow down and do this work? And that wasn't the feeling that I had, or my expectations that I had going into the operating room for the first time.
I will second that. It is really, really cold. A lot colder than I had imagined.
Right.
And then you're not wearing, we're wearing like
you're wearing scrubs.
The scrubs, and there's nothing covering you, right? Because you can't.
Right. You put on those sterile gowns and stuff like that, but they're pretty
flimsy. They're so thin.
Flimsy, yeah. And so that, in the scope of all that's going on, seems like something that is not consequential, because someone's life is on the table, right? Someone's on the table, they're out from anesthesia, right? And they're being operated on. But as a med student, where you're not able to really put that priorities into perspective, it's just like, oh, why am I so cold? it's all I kept thinking. It's like, why is it so cold in here? And that was like the quintessential feeling that I had the first time I went into the operating room. So yeah, that's a long-winded, answer to your question, how I was feeling when I went into the hospital. But yeah, I think excitement and fear was pretty much how I felt going into it. How about you?
Yeah, I remember my school, essentially they gathered all the rising third-year students, like to the end of our second year. We went to the auditorium, then they were handing out envelopes with our rotation schedule.
Okay.
And it was totally random. You had no choice in what overall schedule you get. They had some preferences you can list preferences as to what site you want your specific rotation to be at, but not the overall layout of the schedule.
Mm-hmm.
And no idea. And I was nervous. I got it. I was like, okay, like, you know, and I opened it and it said surgery first, and I was like, oh no. And it's not that I didn't like surgery, just from what I had heard, it's a tough one to do first.
Right.
And, you know, we know into why, but, you know, it definitely, and the other thing was I was asking my close friends, and like none of them had the same schedule as me. So I was a little nervous as well, just because, you know, I don't know everyone as well as I do them.
Right.
So maybe I didn't have as best support system. So I was thinking about that too. But, you know, it's still exciting to be like, okay, I'm going to go in the hospital. I can finally actually like maybe be helpful to someone.
Right. So did you guys have to do rotations outside of the main hospital that your school was associated with?
So my school had kind of multiple hospitals depending on the rotation. So there was the main teaching hospital.
Mm-hmm.
That teaching hospital had two main campuses. Then there was like a bit of a satellite-ish campus, still part of the main system, but they didn't have every rotation there.
Okay.
Then they had the public city hospital,
Mm-hmm.
and that had quite a few rotations. That was also nearby, and they kind of had an affiliation.
Okay.
Then they had maybe some smaller practices, depending on like family medicine or psychiatry, that they may send you out for.
Okay.
Yeah.
What was it all within the same city? Like, because you went to med school in New York, right?
Yeah. So basically, schools in the Bronx, and most of those hospitals were and centers were in the Bronx. I think there was one site for a couple rotations, the hospital in Brooklyn,
Mm-hmm.
and then one, I think, psychiatry potential site in Manhattan, but that was basically the extent. And it was nice. I will say, I do give props at medical school. They did arrange transportation. So they paid for all the transportation, whether it was a shuttle or a paid vehicle that you could reserve online to get you to places.
That's a very well arranged system you guys have.
Yeah, you know, other schools, like students will tell you have to drive yourself and figure it out, but they helped us.
Yeah. So our rotation system was actually a lottery system. So you get different like slots to pick your choice of rotation and where. So where I went to medical school, you know, it was the main hospital, right? And then we had 3 other satellites within the same city, but then you get to go as far as Pittsburgh, which is like 4 hours away, right?
It's really far.
Right. And then you can go to New Jersey, right, which is maybe an hour and a half in terms of the hospital that we were associated with, right? And, you know, you had an option even in third year to also like do some kind of like away rotation, but like, you know, it's not quite like the 4th year away rotation. So there was a lot of like, you know, uncertainty associated with that, which is not too dissimilar from what you had, but yours was kind of determined for you, right? They already determined that for you, and then it was mostly in the same city.
Before the start of every rotation, we can put preferences as to like what site we wanted.
Okay.
But, you know, that was like, who knows what you're going to get.
Right.
But the actual order of rotation was definitely already laid out, like your track.
Yeah. And, you know, we didn't have transportation per se. And within the city, you know, you could drive as far as maybe 30 minutes, 40 minutes to a site that you have to do your rotation at. But if you're doing it in, say, Pittsburgh or like New Jersey or even in Bethlehem, PA, right, which is where, you know, St. Luke's Hospital is, right?
Right.
They give you like a dorm room. But, you know, if you decide to do that, you know, back and forth, right, every day, that is something that you got to figure out in terms of transportation.
Gotcha. So basically, if you're from there or something, it's easier. But if you're not,
right. I mean, if you're from there, so I knew that, you know, there were a few Pittsburgh guys, right, or people that live in the Allentown area. You know, they have family there, so it was easier for them to just say, "I'm going to stay home, right? I don't want to live in a dorm."
Yeah.
I don't want to live in a
they get
dorm.
to see their family.
Right. And so that worked out for them. So there's ways that, like, even if you got Pittsburgh and someone who's from Pittsburgh didn't get Pittsburgh, you could maybe trade with them, and that was possible. So that was something that we could also do if you wanted to trade spots with someone. But it's just like I was not interested in going anywhere further than an hour. I did my furthest rotation was probably in St. Luke's, which is maybe an hour and a half. There was a dormitory there that we could stay, but it was like almost like a monastery, like nothing. You couldn't have like electrical appliances, all that kind of stuff. At that phase in my life, I was not interested in living in a dorm because I went to boarding school for high school.
Wait, so you couldn't even bring like a toaster or microwave?
No, they were concerned about fires. So you couldn't do toaster. They did have a fridge there,
but no microwave.
I believe there was a microwave, but that wasn't necessarily legal to have it in the dorm.
Gotcha.
Which is really weird.
That's really difficult for being a med student.
Right.
Hours,
right. And they tried to give us like a little bit of a stipend to buy hot food in the cafeteria. But I remember there was a fridge, there was a microwave, which technically was not legal to have over there, but it would have been unreasonable to not to have a microwave, right? And there was like a twin bed you had, and that was it, right? And that idea didn't really jive with me. So I had a dorm room, but I never really stayed in it. I just drove every day for my rotation. So that was like an hour and a half one way. So 3 hours driving every day. And I was like, no, I'm not going to stay in a dorm room for this. Mm-hmm. But yeah, that's some of the stuff that you got to really think about, because like that's not something I expected. Like going as far as Pittsburgh when I applied to a school in Philadelphia, right, was not necessarily, what I had in mind, when I was going to med school, right?
Yeah, and that transportation, even for me, wasn't as like far, but it definitely, is a time sink. Right? Mm-hmm. You have to allocate that transportation time. You have to make sure you're waking up early or coming back a certain time, and have to adjust your whole schedule for that. Mm-hmm. So Hilario, what was your first rotation, and how was that?
Yeah, my first rotation was in OB. And OB was interesting for a number of reasons, right? Like, you spend half of the time in gyne clinic, and then you spend a good number of the time with the obstetricians, right? Delivering babies and seeing C-sections and stuff like that. And then I spent a little bit of time also doing gyne-onc because I knew I wanted to do oncology. So, OB is like definitely not my preferred like first rotation before I went to medical school, right? So if you had asked me, I probably would have done some kind of internal medicine, because I feel like internal medicine is sort of like the backbone of all medicine, right? You learn everything in general terms, right? And then you kind of riff off from that. Like you kind of like adjust a little bit when you get to OB, you adjust a little bit when you go to nephro or like some other specialty. But like before we get into third year rotations, we do learn a little bit about what normal labs look like, what normal physical exam and all that kind of stuff look like, right? And then so to go from that to OB where everything is different, right? Like, labs are like off, right? You look at it at face value. If you're not told that, this patient is a pregnant woman, right? You would think all these labs are like abnormal, right? And in terms of like hemoglobin, right? Because like we know like pregnant women like have a lot more plasma, so their hemoglobin tends to be a lot lower than the average person if they were not pregnant, right? So like all of these like little differences, right? And the things that matter even to the attendants and what they want to hear, right? It's like so different. And not starting from that super specialized type of rotation was kind of like disorienting, right? In the very beginning. But also I think like another way that you can flip this is that like it was just like a good way to be adaptable, right? Like you're thrown into something that you're not necessarily expecting, and then trying to like readjust yourself and learn on the fly. It was pretty interesting. I had not done pelvic exams before that, right? And definitely on your first day of OB, you
basically what you're doing, right?
that's what you're doing, right? If whether you're in gyne, people are coming for their gyne appointments, right? And we have to do pelvic exams, so you do that with either a midwife, a nurse, or the attendant, right? You learn to do pelvic exams, right? And do, speculum exam, pap smears, right? All that kind of stuff. So that was like like a first day medical student rotation. That was like very eye opening, right? And then, you talk about the time that you spend in labor and delivery. So I did my labor and delivery. I had 2 weeks of labor and delivery. The first week was during the day, and apparently babies don't like to come during the day.
They never come, ever.
So I had maybe like a couple deliveries that I was part of, and then the following week was the night. And I remember just waiting. It's like, oh man, I'm only going to have like 2 deliveries this whole rotation, and that thought I felt like jinxed everything because we had like 8 people that were like in labor by 3 o'clock in the morning, and like everything was a chaos, and everything was a chaos. Like 3 a.m. That's when everybody went into labor, and it was very, very cool because there were so many deliveries, and I got the opportunity to be able to like actually like help deliver babies, and that was a really cool experience. I remember coming the next day and my wife telling me that like I looked very bewildered, like my eyes were like going to pop out of their sockets, right? And that was because I came out of it. I was like, oh my God, I don't know how the time passed. So from 3 a.m. to 8 a.m., right? I was there till the next day, right? 8 a.m. It was just like nonstop, like
Right.
doing something.
And you can't just, you can't stop. You're on the clock of
Right.
patients and delivery.
But the thing is, you don't feel it. You don't feel like the time is passing because there's so much happening. People are like in labor. There's a whole lot going on, and thankfully there were no emergencies on that day. And then the next thing was like it's an emergency C-section, which is like a crazy experience, right? For some reason, I think I had been told that like when you're doing emergency C-sections, like when you're doing C-sections in general, like people are not under anesthesia for the most part. I didn't realize that was the case, and just seeing an emergency C-section, and then they put this like gown across so that the woman doesn't see what is obviously going down there, where this abdomen is literally ripped open, right? And then that barrier fell, and then she saw it. Yeah, I know. I don't know what happened, but it fell because it was held together by like clips, right, on one end to the other end, right? And one side fell, and then she saw us trying to pull the baby out of it, and then she's like, "Get it out, get it out!" It was very traumatic, and it was very intense, and we quickly put a thing up, and we calm her down and say, "Yeah, we apologize for like kind of like not having a very good physical barrier," but that was like really frantic and very interesting. And I came out of like OB thinking that like if I wanted to do OB, I probably would want to be in obstetrics, not gyne. But then obstetrics is not oncology, right? So I was yeah. So that was where I got lost a little bit. It's like, okay, maybe not OB, but
yeah, that I just want to comment on that C-section story. C-sections were nothing like I thought. You look at the scar and it's like, okay, I mean, they have a scar, but I mean, it makes sense that you're literally cutting the abdomen open.
Right.
Them being awake is wild.
Right. I mean, obviously they don't feel the pain, but they can tell you they feel the pressure, right? Of you trying to like, take the baby out and like kind of like opening up the abdomen, right? And it's just like the craziest thing. Like,
yeah, I was in some ways amazed, some ways mortified, all at the same time.
yeah.
I will say, I've some of my girl doctor friends and med school friends, they would see it. They're like, "There's no way I'm getting an elective C-section ever."
Oh,
I don't blame them.
right.
I was like pretty amazed
Yeah.
actually.
So I came out of it thinking, oh my God, OBs are like, you know, very, very, very talented, and it's like very remarkable specialty to be able to, to deliver babies and like see new life, right? And at the same time, I was like, if I was a woman, I would never have a baby, whether it's vaginal delivery or whether it's like C-section, because like it just seems so traumatic and so like so much involved. And I just can't believe, like, maybe seeing a new baby kind of like takes all of that away. And I think I've heard my mom talk about how like, oh, it's so much painful leading up to everything, and then once you see the baby,
Once you
you're like,
see it,
you kind of
yeah,
like,
that makes sense.
it makes you forget all of that, the pain and all the trauma associated with it. But like, I don't think I would be able to have a baby.
Yeah, I'm not gonna lie. The first delivery I saw, and I think some of these formative experiences really end up shaping like your thoughts on
Right.
things, right? And first of all, it's like the head is, and it's just sticking out, and
Right.
it looks, it's interesting the way it looks.
Right.
And the head for this baby was like sideways, and
Okay.
so it wasn't, I guess, in like a proper position,
Right.
and then they had to take like a forceps and like try and turn it, and it was just a very
right
like traumatic thing.
Right.
And I feel like I was traumatized. Like, the mom was like, whatever, just like
right.
do something.
Right.
I was like, oh my God, what am I doing
right now? Right. And babies, interestingly, are very tough. Like, even when you're delivering them and like pulling them out, in different ways, like you think you're gonna break them. Obviously, you don't want to be super aggressive with it, but like the kind of maneuvers that like you're taken through in like a vaginal canal, like birth, it's like just remarkable how resilient the human body is, even before they start like taking their first breath out of their mom. It's just impressive. Another story was, I had this like this patient, I think that was probably like her seventh baby. And I was like, this is before I had that 3 a.m. like slew of like deliveries. And so I was eager to try and get like a few deliveries under my belt, right? So she was the only one that was like on that day was like in the delivery room. It was like in the afternoon or something like that. And I was trying to kind of like get close to her, get to know her, because that's the one thing that our attendants emphasize, is that like if you're gonna be in someone's delivery, right, they don't know you, so you introduce yourself, try and like build some rapport between yourself and this individual that you're just seeing for the first time as a med student, right? So that when you're in the delivery, you can be a source of like support, or someone that like familiar with them, right? So you don't want to just show up in the delivery room without actually ever spoken to the patient, right? Anyway, so I go and I try, talk to this lady, what her expectations are, how she feeling, all that stuff. And before I left the room, I asked her if she wanted something. She said, "Oh yeah, I think I want some ice." And I was like, "Okay, I think I can get ice." But like med students, like half of the time we spend maybe a good number of our time lost in the hospital. So looking for the ice, like the kitchen on the labor and delivery floor, and getting ice for her took maybe all of 5 minutes, right? When I came back, I swear the lady had already delivered, because she had so many babies. It just passed so quickly, and I just like, it was just so remarkable. So I wasn't able to be part of it, but it was just like interesting how quick she was able to deliver that baby. And I was like, okay, well, note to self, and make sure that if it is someone who's had multiple babies, that you stay close so that you don't miss a delivery. I thought that was pretty interesting. Yeah. So you had surgery as your first rotation. what was your first day like on surgery?
Yeah, my first day. So, starting with surgery was definitely difficult. I think for a number of reasons. One, you immediately have to change your sleep schedule and get there really early.
Right.
Because you got a pre-round. I was there at 5. Go through all the patients, just figure out what you can. One thing, and this is one thing I don't think I think I was able to get much better at, but you have to carry the bucket around as a med student. And I don't know if you remember, but for those of you who don't know, there was essentially this tool box, tool bucket, where you put in tape, gauzes, and all this stuff.
Oh, so yeah, I know.
Yeah,
I know.
yeah.
What you're I don't think we called it a bucket though.
I don't remember the name. I don't remember what we used to call it, but the tray thing.
Right?
And I had to make sure that I had enough for every patient, and that as soon as we get in the room,
right,
I know exactly what we're gonna do. Are we gonna change that gauze? What gauze? How much gauze?
Right.
And I'd have to just whip it out and open it and give it to them, or give it to them and cut it. And I had to have. I ended up by the end of the rotation, I had a method of where I was putting my scissors, where I was putting which gauze, and which pocket in my white coat had which thing in it.
Right.
Because, man, they judged you really hard if you did not do that properly.
Right.
Residents, they were very upset about that. That makes sense, it's part of their workflow.
Right.
But I don't think it was ever really taught, and it was just something you just had to pick up and do. But I always felt a little undervalued. But I think my first day, I didn't know what to expect, and it wasn't really ever explained to me, and it's just kind of something you pick up. At least I felt that was also the case for other people who took surgery. We had many consults in the ER that we had to evaluate, and I would go with the resident and evaluate them. And there's all sorts of stuff, whether it was some appendicitis, or I remember doing the pelvic exam in the ER, and that was I had done one as a practice pelvic exam in my second year, but this is my first real pelvic exam with a surgery resident in the ER. And it's a kind of very chaotic environment, and that was interesting. Then we had challenging conversations with people about what we couldn't do, and I was just kind of there for that. We put an NG tube in a couple people, and that was my first time doing that.
What's an NG tube for people who don't know what that is?
Yeah, so essentially it's a nasogastric tube, and you put it through the nose, and it goes through the nose and then to the stomach, and you do it for a variety of reasons, but maybe you want to have them avoid intake through their mouth, and so then you feed them through this tube. And there was, I guess, a specific technique that I was taught. I would try to follow it, and it was see one, do one, teach one.
Exactly.
I definitely did not teach one after one. It took me a few, but
right.
But that was interesting.
Yeah.
It was definitely the dynamic of the surgery team was. It was definitely moving. Things were moving very fast. People were running from the floors to the OR.
Right.
And you kind of just had to figure things out as a student. I do think it was the dynamic, and I had compared this a lot when I went on other rotations. It was a more, at least my experience was more a confrontational, or I think more of a stressful environment than maybe some of my other rotations that I felt.
Yeah, but do you think maybe there's a point to kind of the attitudes and the regimented what's it called, atmosphere of surgery?
Oh, for sure. You have to be like that, because every decision you make is so important.
Right.
You need the surgeries to go well.
Right.
And I would want my surgeon to be very particular about how they're, caring for the patient, preparing for it, changing all the wound care stuff, asking pointed questions. and doing the surgery in the OR. Like, I would want them to be like that. So I have no problem with that. Just as a student, when you're starting out, it was just very different.
Right.
You don't expect it.
Right. So, I mean, I do think like in a lot of ways too, like, different specialty attract different personalities, right? And I think you have to be a particular type of personality to be attracted to surgery, to be attracted to oncology, right? To be attracted to internal medicine, right? So, while that like surgery comes with that stressful, there are people that really enjoy being in that high, like fast-paced, intense environments, right? And they actually do very well in those situations. And you certainly want people like that, right?
Yeah. I did like, as a student, I could go into the OR and kind of watch them if I wasn't helping out on the floors. And it was really cool, but so robotic surgeries, open surgeries, and kind of all sorts of stuff. I will say the OR culture really was like sudden culture, like the OR nurse owns the OR, like listen to everything she has to say or he has to say.
Right.
I did, but it was really cool to see the surgeries.
Right. Did you guys have different different subspecialties in surgery that you get to rotate in as a med student?
Yeah, so I think my rotation was 7 weeks, if I remember correctly. About 5 of those weeks was like general surgery, and I quickly realized that I was not interested in the actual like problems, that it just wasn't as stimulating to me, like appendicitis, cholecystitis.
Right, for general surgery.
Okay. But then we had kind of like 2 weeks that we did kind of subspecialty stuff, and I did see some colorectal things, which were, man, they were interesting. And I gotta say, there's a lot of poop in the colon, man. Like there's poop all over. I mean, it just gets all in your gloves and like all sorts. I remember like holding the colon and holding it with the equipment and the surgeon kind of making the incisions and whatever. And man, it gets messy. It gets super messy.
Right.
More all props to the surgeon themselves. I saw some urology cases of robotic prostatectomies, which were really cool to kind of see.
And that is relevant to us as
it's relevant to us,
right?
Yeah, definitely relevant to us. At the time, though, I didn't know it was going to be relevant, but it was relevant. I saw plastic surgery. I was really amazed by plastic surgery. Really, it was so interesting.
It's intricate and very delicate work, and it's like you have to be like very meticulous about what you're doing, right?
Yeah, the microscopic surgery. They're literally looking in a microscope and making these very minute movements. And there was some elective, like breast implant things that are totally elective, but then there was also this, these really, crazy reconstructions of an injury or a burn or something. And it really did open my eyes to different, I think, subspecialties and different surgeries and kind of where you can go from there.
Right.
But it was fascinating. It was really long surgeries.
Right. Yeah. So, I mean, like you go in surgery, you go from like, doing surgeries like cholecystectomies or appendectomies, right? And like where you just like resecting like, certain parts of the body without a whole lot of finesse, if I can say that, right? And then you go to like, recon, right? Where like they're like slowly doing, surgeries, and like it's like so meticulous and very, very, very like control setting. So like for me, like I did bariatric surgery, and I did transplant, right? And then on ENT, I did see some head and neck reconstruction, and it's just like there's so many facets to surgery that like, even if you're not someone who is like, wants to be in that fast pace, like, running around trying to like put up fires kind of thing, or like trauma surgery, for example, you can be someone who does recon where you can actually like, slow down and like do your work, in a very meticulous way and like in a very delicate way. So even within surgery, I felt like there was so many aspects to it that really attracted me. I like the structure of like surgery. The thing that probably wasn't for me in surgery was the amount of time you actually get to spend with a patient. Most of the time, your patient are asleep, right? Majority of the time that you spend with a patient, they're not awake, and you don't really have that, conversation, that, relationship as much as maybe some other specialties like oncology, where we spend so much time talking to our patients face to face, right? So that maybe was the thing that wasn't for me when it came to surgery.
Yeah, I would say, and they'll tell you have to love the OR. You love it. And if you don't love it, then it's not for you, because that's where you're spending most of your time. And I liked it, but I definitely didn't love it.
Right.
Yeah, I would say it's a really interesting experience. And it's, again, it's kind of like, we'll never do it again. So it's really cool to take what you can from it.
Right.
I would say a few things I didn't like as much. So as a student, it was tough starting with surgery because, as a med student, you end up doing these rotations, and at the end of every rotation, you have this shelf exam, or like a mini board exam. And I felt like the entire surgery exam was based on your knowledge of internal medicine, and I had not taken any internal medicine, so it was very difficult for me to kind of study and do well.
Right.
And again, it's also your first rotation, so sometimes that can be challenging to figure out what you can do.
Right, figuring out how to even study, because in these like rotations where you're doing clinical stuff, you have to maintain the schedule, right? You got to come in, early in the morning, like at least when I did surgery, reporting around like 5:30 in the morning, right? Yeah. And you're not leaving till like, 6:30, 7 o'clock, right? And then having to also study for your shelf and knowing, how to study for that, because you don't have a whole lot of time to do that. I think for me, the thing that really was like a little bit of an adjustment that I had to make as I started doing rotations was realizing that sometimes your grade was not necessarily in your control. It was always like a little bit more subjective than, majority of your school life, right? Majority of your school life, you're reading a textbook, or you're going to lectures, and then you're taking a test, right? And then like doing well or doing however you do based on your book knowledge, right? But like on rotations, it was your performance and like how you carried yourself, right? And how you presented, the patients that you were seeing. So it was a little bit more a subjective kind of like assessment of you as an individual. And so that was part of your grade, right? And the other part of your grade was taking this like, shelf exams, right? So for me, like, kind of adjusting to what kind of impression that, I give off to my attendants or the residents, because that will affect your grade as well, right? That for me was like, for the first time, it wasn't just you just taking control of your grades, right? So
yeah, the subjectivity is real.
Right.
After the first rotation that everyone finished, essentially every one of my classmates would ask the other classmates on the rotation they're going to be on, like, hey, how is your site? What are your thoughts about if I should rank this site high or not? Because sometimes some sites people would grade easier, or they would have lower expectations. And your grade would be significantly impacted by that. So it was really also like a game you're playing. Where can I go? Even if this site is closer, I can like walk to it. Maybe I should go take the car and go farther because my grade is going to be, better.
Impacted by that.
Yeah.
So, I think that part of it, if I was a med student today, knowing what I know, I think part of it is also, having that conversation with either your attending or like some of your senior resident, like what is the expectation of me? Because I feel like when you start rotation, especially in surgery, on the first day you're thrown into chaos, right? You never really have that time to really talk to anybody about what the expectation of the rotation is, you probably see, I saw my attending on surgery when we're doing surgeries. And then after that, I was mostly with the interns and like the residents, right? For the most part.
Yeah.
But a good majority of your grades comes from the attendant, and they ask the residents, right?
Yeah.
So there's so many tiers to how you actually get evaluated. So I think, like, as a med student, if you start in a medical school rotation, you want to, if you have the opportunity, just ask, oh, how am I going to be evaluated, and what can I do better, even every week, right? Okay, hey, how can I be better at this, right? And I think I realized that maybe in fourth year to really ask those questions and like and get that kind of like feedback from senior residents and like attendants. But in third year, where you're mostly like kind of like afraid, right? Or mostly they're trying to just like not look stupid. That was the primary thing, right? You're not trying not to look stupid. You forget to like step back and actually think about how you're going to be evaluated and what your role is on that team that you find yourself in.
I wish I knew that before. I started doing that in like middle of my third year, but that was I wish I knew that. I will also say it's always an adjustment. I didn't feel like I really knew what I was doing until like late October, when.
So late October would be what,
It's like 3-4 months in.
3-4 months in. Okay.
I feel like I started surgery, then I had family medicine, and they both weren't. Okay, actually, maybe earlier October when I started pediatric rotation.
Mm-hmm.
I think that was the first rotation where it was like, okay, expectations were shared. They would actually teach. I feel like they were actually teaching, and that I started to learn like the medicine of things. So it takes time, and then you've already been through a couple of rotations, so now you realize, oh, what are these exams about? How do I study? When can I do these questions on my own time? So I do think that just continuously evolves as the year goes on.
Right.
Being comfortable with the situation.
Right. Yeah, good point. So, I mean, let's kind of move forward. So, third year, right? You're doing internal medicine, you're doing some surgery, you're doing some OB, right? I did neurology. It's another one that you take in third year, right? So, moving to fourth year, I'm assuming by fourth year, Aneesh, you knew that you wanted to do radiation oncology, right? So, what was your game plan? Like, what is the game plan of a med student when they decide what specialty they want to do and they're starting fourth year? What was the process like for you?
Yeah, so I would say the first thing was I went back and thought about radiation oncology. So I was able to do like a 2-week elective in my third year. And I wanted to do that just to confirm, I really like this. I mean, it sounds like a short time, 2 weeks, but I think that
it's a lot of time, actually.
Yeah, but it is a lot of time. And I think when you go on your rotations, you'll realize stuff you really didn't like and liked about each field and what you could really see yourself doing. So, for example, I realized, though, most of med school you learn about physiology and physiological pathways, that in practice, I really didn't actually like anything about physiology for the most part.
Right.
It really was not my thing. So general medicine fields, especially things like cardiology, I just like cannot do it. I literally I feel like my brain was just shutting off,
right,
because I just couldn't get into it.
Right.
Anatomy was definitely more my thing. And, so I think you go through things like that where you'll see what you like and dislike. Another thing in a practice standpoint is like rounding. I really didn't enjoy rounding.
What about rounding? Didn't you like?
Yeah, so I thought I would enjoy, it's where you're conversing with your fellow colleagues.
Right. That's the quintessential, getting the team together, right?
Right, getting the team together, conversing about the patient cases and making those decisions. But what I personally felt was it was a lot of conversing without concrete decision making. Sometimes you still have to wait on a lot of things before making any decision.
Right.
I felt like my rounds sometimes were also 3 hours, and you're just kind of in the hallway for 3 hours standing. And as a resident, trying to put in orders, like taking the computer on wheels, trying to put in orders, but still not really, quote unquote, getting things done until after the rounding's over.
Right. Right.
And I wasn't a fan of that. And honestly, I didn't have the attention span for that. And that's personally, I was losing attention after like 30 minutes. So maybe that's just reflects poorly on me, but I mean, I know I wasn't the only one. I'll say one funny story about my experience rounding. There was a solid month, and my internal medicine rotation was very long. It was 11 weeks, and I felt it was very tedious by week number 8.
Right.
But I really, in order to make myself awake, I want to see the John Oliver show. It was in New York, and he had a free show.
Right.
But you had to log on to his website and put your name in at exact time every day. It was like 9:30 or 10 or something like that.
9:30 in the morning.
Yeah, or something like
that. That's peak time for rounding.
Yeah, it's peak rounding time.
Okay.
So
okay.
Every day I would, it's like 9:30. I'm like, all right, I'm gonna excuse myself for 1 minute, and I would go open my phone, put my name in his lottery system for like a few minutes, and come back. And I felt bad, but at the same time, it gave me something to look forward to. It like made me more engaged. Unfortunately, never got.
You didn't get in?
I did not get in. It was really fortunate. But a couple of my friends did.
Okay.
Yeah, it was unfortunate.
Yeah, I mean, like I felt like rounding was one of the things that, like, remember I told you when I volunteered at a VA hospital, seeing the doctors round and like just standing there as someone who wasn't yet in medicine, right, was kind of like inspirational. It was kind of cool to be part of the gang, trying to figure out what is wrong with the patient and like what the solutions were going to be, right? And I think I had this like nostalgic or like romantic feeling around that idea when I got to med school. That, I remember being in the VA volunteering, and there were like this other guys who were in like white coats, and I wanted to be like them, kind of like making decisions about someone's care, right? So I thought that feeling was going to be transplanted into when I started rotation. I did like rounding because that was the point where you get to put your best foot forward, right?
Yeah, that was a nice part.
All the attendants were there, the residents were there. If you prepare well for your presentation, this is the chance to impress everybody and hopefully get a good, assessment of your skill, right? But at the same time, you're presenting and there's like 12 people looking at you and they're very close to you. They're standing right there in front of you, right? And you're in that environment where you have to impress, and any little mistake can be seen as like some failure on your part, right? So that was in of itself very, stressful. But I think some stress is good, as physicians, the job that we do, we have to learn how to like tolerate stress and like be able to, rise above it, right? The other part of rounding that I felt like was maybe not for me was that there was so much redundancy, so much like what I would probably say, I would probably say that it's a waste of your time, right? Because the agenda wasn't very clear at times, where, we know that we're going to go through every patient, but like often we get sidetracked doing things that like end up not helping any of us or even the patient, or being interrupted by someone else, right? Or some consulting physician would kind of chime in and like derail us from like what we were trying to do. It's not like you're sitting. I mean, I had a few rotations in my residency where I actually did sit and run with like my attendants, which was like, and then we had coffee. We're very efficient, but you felt comfortable doing that, right? But like for the most part, like where I did med school, we're standing on our feet for like 3-4 hours in the same place. It's not like you're moving a lot, right? In the same place, right?
Yeah.
And half of the time that you're spending doing that, like, didn't really matter. Or, we had to still go back after doing all of that to do those same things. But now actually make the real decisions about those things that we discussed before, right? So there were so many like inefficiencies that I can get a little bit impatient about, right? That I was like, oh, I mean, we talked about this yesterday, the same plan, right? And the patient is on track to meet those goals now. Why are we wasting time doing this thing over and over again? Because we know it's not going to be helpful for us to do that. So that, and obviously as a med student, there's no way you're able to discern that and also be able to have the authority to speak that to your superiors, right? The residents half of the time didn't like that, that system either, right? And if I'm being honest, some of the attendants did not, but that was kind of like, it's the tradition, right? Is the tradition of medicine that people did. So like we just kind of like did that, and we didn't think about whether actually that was going to be efficient. And I think efficiency matters in medicine, right? And so for me, that was the.
Yeah, I just want to put the caveat for everyone listening. This is also to radiation oncologists. I'm glad someone likes rounding out there.
So they can. Right. I mean, obviously, we are radiation oncologists, and there is probably some sense of like our personalities and what we want out of medicine that makes rounding the thing that we do not want to do, right? So that makes sense. But I think I know internal medicine physicians, because if you go into med school, mostly up to half of your class is going to be internal medicine, right? So you all the people that like internal medicine, there's a lot of them that also do not like rounding, right? Because of the way it is done, right? So
and then they may end up specializing into something,
right? And they end up, and usually more often, internal medicine is like I said, is the backbone of all medicines, really, right? More often people end up specializing into something else from the primary internal medicine, right? So like if you do gastroenterology, if you do hem-onc or medical oncology, right? If you do nephrology, like there's so many specialties where you have to do internal medicine and do that kind of rounding and then move on and to do something else, right? And I think it's fair to say that there are a lot of internal medicine people who find rounding inefficient. That's a fair thing to say. Fair. So I mean that was maybe my thing about rounding, but I think I got the point of it.
Yeah.
But there was also inefficiencies associated with it.
Yeah, I mean that's definitely one thing I didn't enjoy doing. I mean, even the other rotations like radiology, I really liked radiology, but I realized I needed direct patient care,
right.
And then I want to do cancer care, so I kind of have to rule it out. But you end up liking certain things about every field and disliking things.
Right. Yeah. I mean, I think it was the thing about every rotation was that you want to find out what you like about a rotation and what you don't like about the rotation, because that can help you kind of narrow down your options. And even if you don't like something about a rotation, right, there are certain things you can live with and there are certain things you can't live with, right? Like you mentioned with radiology, right? I loved radiology rotation, but I think something that if I was a radiologist, I probably couldn't live with was not having that patient contact where I actually get to like make decisions around their treatment decisions around their care. I think that was like a non-negotiable for me, right? But it was everything else about radiology is really cool.
Yeah, it's awesome,
right? Being able to look at the image and like know what is abnormal, right? Yeah. And sometimes it's not very clear to the normal eye, like other physicians can look at the same image and not be able to tell you what is wrong. But if radiologists will look at it and tell you this, and that, it's like, how do you see that?
You learn a lot from the radiologists, and they have a good, good quality of life. with patient care, and you do realize it's under rotations, there is that kind of emotional burden, that stress is always there. And when you're in radiology, they have their own stresses, of course.
Right.
But it's not a direct patient interaction, but, managing the patient kind of stress and emotional burden, which really can be very helpful for your own sanity and quality of life.
Right. Right. And I mean, the caveat here is that there's subspecialties in radiology, right, that have a lot of patient contact, right? Like interventional radiology, they tend to actually make treatment decisions about patients, right? And then if you're doing some breast, right,
you'll see patients.
You see patients, breast imaging, right, and breast biopsy, doing biopsies and stuff like that. You
will get that patient interaction,
right? You get some.
Also help save yourself from that kind of emotional burden.
Right. So there are some people that would really attract, right? Another neat, what's it called, specialty that I thought was also like very integral to medicine, but we never really saw much of, was pathology, right?
Yeah,
like pathology is actually very close to what we do in the first 2 years of medicine, right? Like all those slides that you see in your first aid, what's it called, textbook. So the first aid textbook is like the Bible of like the first 2 years of like med school, where we use that to study and do well on our board exams. You see a whole lot of pictures, and most of those pictures are coming from pathologists, like those stains that you see, right? And I feel like we have that contact with them in the first 2 years in terms of the book knowledge, but then like when we get to the floor, we don't really see the pathologists.
Yeah, they're like hidden somewhere. I think I spent a couple of days with them. Actually, I think it was really funny. That's right, in my third year med school, the pathology department, because it wasn't a required rotation, they actually paid. They gave like a paid 1 week stipend for a student who wants to rotate with them. Yeah, it was really interesting. I mean, I didn't have time and I wasn't interested, but
because they wanted to attract
they
students.
Wanted to attract students. But I mean, it's a cool field, and that's your thing.
Yeah, it is cool, but like you said, we never really see pathologists, right? Yeah. Maybe in oncology now we see pathologists a lot more,
we
right?
Interact with them a lot, right? We even know people's names. We know their names,
right? Right. So now, like in oncology, for example, like when we do our tumor boards, we actually have pathology there to explain to us what is seen on the slides, whether something is like cancerous, right? Whether the margins are positive or not, right? Like this kind of stuff are like stuff that are things that we need a pathologist to kind of clarify. But like I feel in med school, we don't necessarily
it's interesting. There's like world famous pathologists that I know the name of now just because we've had patients, they've sent slides to that institution and they've reviewed it, so, but it's not something you think, is a thing.
Right.
Yeah, and I would also say that, there's all these subfields that you may not have any idea about, that just, let's say, for example, maybe you don't like internal medicine, but there could be this subspecialty or subspecialty that you actually think is so cool, like, like electrophysiology or interventional gastroenterology or, interventional nephrology, all sorts of things. And additionally, just when you go on rotation, just keep in mind sometimes your experience or your thoughts on the field may not really necessarily be about the medicine, but just maybe about extraneous factors of your experience. And I think that was because all those factors are so influential and sometimes in helping you choose a field. Like honestly, I thought my internal medicine rotation, I did half of it on one site, half of it on the other. And one site I ended up doing other rotations on, and I felt very sad in that hospital. And I don't know if it was like the lighting and it was just like dim lights. Or
the lighting?
And it was like it was like a Bronx City hospital where people, have no money. They were just, these really advanced problems.
Mhm.
And it just felt like it was so difficult to help people.
Mhm.
But also, yes, the lighting was, I'm not gonna lie, man, that lighting really stunk.
So if I'm hearing you right, you're saying that, making your decisions on what you like about a specialty might not necessarily really be about a specialty, but it might be that particular hospital that you're in.
Yeah, it could be the hospital, the cool mentor or the not cool mentor, that you have can all be impactful.
Right. And I think the opposite is also true. So like for me, I thought that ENT was the thing for me. And the only reason that I think I enjoyed ENT to the extent that I did for the first 3 years in medical school was because of the mentor that I had. Right. But then once I saw, in other ENTs, I went into the OR, right? And I went to a conference for otolaryngologists, right? That's when I realized, okay, like I don't necessarily think this specialty is what I made it out to be.
Right.
So the opposite can also be true about if you really want to have like a very broad and holistic approach to what you decide to go into, that could be something that you need to factor in, right? To really realize about a rotation, about a specialty before you make a decision. But at the same time, too, it could also just be that simple, right? It could be that, you like your attendant or your mentor, and so you want to be like them, and that's fine.
It could be that simple.
And you learn to love your rotation or your specialty later on, right? And it could be that you don't like a specialty because you met someone in it and that puts you off. And that's fine because you're probably going to end up doing something that you like better than, the thing that you didn't choose because someone, put you off. Right. So it might be as simple as how you feel on the rotation. And, it could be as complicated as really thinking and writing down the pros and cons of every one of them. And I think
at the end of the day, it's like gut feeling.
Right. At the end of the day, you're going to make it not just on some super rational decision. Some of it is going to be an emotional decision, and that's okay. That's fine too as well. So yeah, so back to fourth year. So, you now know that you want to do radiation oncology. You definitely want to do those rotations first, right? To try and get letters of recommendations, right, for your application into residency. And then there are some, away rotations that you maybe have to do, right? Did you do any away rotations, Aneesh?
Yeah, so there's definitely some specialties where they recommend or mandate away rotations. Radiation oncology, they highly recommend it because it's a small field. They want to know you really want to do it. Other fields like emergency medicine actually mandates you to do away rotations at other institutions. So you definitely have to
emergency medicine?
Yeah.
Okay.
Yeah. So you definitely have to look at that. And for me, I did 3 away rotations.
Okay.
So when we say away rotations, we mean rotations that are not at your institution. And there are a number of, I think, factors that go into where you might want to go to. And there could be an application process like there is for radiation oncology.
Right.
Most programs have some type of application process, and that program director will have to approve you coming there. I think, some people may say, all right, I want to kind of target this region, maybe just as an example, New York region,
right,
Philly region, Northeast, and be like, hey, I wrote, 1 institution each place or 3 institutions in the same area because I want people to know, like, hey, I want to match here.
Right.
You end up realizing it's kind of a game you try and play. I don't know how to play correctly, but
what do you mean game?
So when you go into the residency application, you are trying to convince these, program directors, attendings, faculty that you want to be at that institution,
right,
and that you will rank them highly.
Okay.
And ideally, so the person who developed the match formula won the Nobel Prize for it. And essentially, it's just a resource allocation formula. It's you rank where you want to go, programs rank who they want, and they allocate someone to each place.
Okay.
But in reality, it's not that simple, because programs actually have incentives to get the person they want high on their list.
Okay.
I remember I attended a meeting at my institution where all the program directors would go around and say what position they had matched. So what position on their list they had matched.
Okay.
And they could even allocate funding and different things based on that. So they are incentivized to match someone who's high on their list.
Okay.
So the reason I say that is when you are doing these away rotations and when you're ranking your list, they will try to get a feel, and maybe not every program, but some programs will try and get a feel for if you're really going to come here, if you're really going to rank them. So maybe you have family in the area, or maybe you have no one in the area, and they may look that poorly unless you do all your away rotations in that same area.
Right.
So, you try and kind of play this game, and some people will do that.
Right, because they don't want to waste their ranking on someone who definitely does not want to come to the place, or like it's not.
They think will rank them lower than they'll rank another place.
Right.
So I definitely thought that for me. I did not do that approach. I did the not so used approach, which was I felt I was, I grew up in Jersey. I went to med school in New York. I felt kind of like in this bubble. I needed to leave. And I used I need to leave at least for some months.
Okay.
And I used my away rotation as an opportunity to experience life elsewhere. So, yeah.
That sounds like you. That sounds like you. Yeah.
So I went to Philadelphia. I went here at Fox Chase Cancer Center for a month. And I had, though living in Jersey, I never really spent any time in Philadelphia. New York was always my city.
Okay.
Came to Philly. I went to Oregon Health and Science University.
Okay.
Great experience there for a month.
Uh-huh.
And I went to University of California, San Diego for a month. And then because I was on the West Coast, I spent time with my family in Seattle in between those rotations.
Gotcha.
So I was really not around for a solid 3 months.
Okay.
And, I don't regret it.
Right.
I had a fantastic time. I experienced life. I'd never really been to the West Coast.
Right.
I mean, I'd been to Seattle a couple times, but outside of that, I hadn't. So for me, it was a really cool experience. And I saw institutions that I definitely would not have seen.
Yeah.
But I'm actually still friends with a couple of the residents I met. And so I thought that was cool.
On the West Coast?
Yeah. We went to concerts together. We hung out together.
Right.
But I think more importantly, it also gave me perspective on different areas and maybe how they practice and different populations of patients. But that's how I approached it. I don't. It's definitely not necessarily the right approach.
Right.
It was just what I did.
Right. I think you take the approach that worked for your particular situation. For you, it was trying to get out of the bubble, right?
Yeah.
For me, it was important that I end up in this area, right?
Yeah.
And so my then girlfriend was, starting her PhD program here in Philly, right? And it was like, we knew at that time that we're probably going to get married and all that kind of stuff,
that's
right?
when you have to decide,
right?
When you're about to rank your list.
Right. And for me, it was important. Did I want to get married and then go live somewhere in California while my wife was in Philadelphia? No. Did I want to be away from her? No, I did not. And so it was important that I matched to at least one school, one of the schools in the area. And it does. I don't want it to be more than an hour drive for me as a resident, because that's a lot of time you're commuting. So all my rotation was in the area. My away rotations were all in the area, because it made sense that that I did that. And in that kind of that's something that you can also tell the PDs, the program directors, when you're rotating, or the residents when you're rotating. It's I'm interested in this program, and these are my reasons. I have a spouse here. I moved from Ghana to Philadelphia area, right? And I've been here for 10 years. So I have roots here, right? So I'm not necessarily looking to move away from this area. And the opposite was that when I interviewed Mayo, right? it was like Minnesota and Philadelphia. It's like, wait, are you going to come here? And I was like, yeah. I mean, if I get into Mayo and that's where I'm at, do I think I will like it here, or do I think that would be a good choice for me? Yeah, because I've moved from Ghana to Philadelphia, right? So I know what it takes to kind of move from one place to another, right? So you can express whatever advantage that you have depending on who you're talking to, right? But if you ask me what was my priority was to stay in the area with my friends and my family and my spouse. But at the same time, if that's not what is working out for you, you gotta have plan Bs, right? And you gotta be able to explain those plan Bs, because program directors are also interested in knowing those plans, right? Why you're picking them, right? And what you're trying to get out of applying to them. Yeah.
Yeah, I would say exactly. They're trying to figure out, where you put them on the rank list.
Right.
And yeah, some of my reasons were, when I don't know anyone in the area, it was not a very compelling, but I did try to make the case like, yes, I want to move elsewhere. Like this is the opportunity, and it is.
Mm-hmm.
It's the opportunity to move elsewhere, put roots elsewhere.
Right.
Ultimately, what ended up happening was I felt I couldn't commit to moving somewhere for 4 years without having any like really emotional support, because it's a big decision. But that's why my transitional year, I ended up only ranking places outside my area.
Gotcha. So how did you rank your residency programs? How did you rank them?
Yeah, so we have our preliminary year of medicine or surgery, depending on what you want.
Mm-hmm.
And then we have rank list. Then we have our radiation oncology rank list.
Mm-hmm.
When I thought about it a lot, I ended up, again, I felt it was difficult for me to commit for that long of a time, especially residency, just talking to people, and they would tell me they think it's really important to have that support system. And I felt convinced to an extent that was true. And I do think things have changed as I've gotten older, had my own experiences, but I do think it's important. And it's nice. My parents are getting old. It's nice to kind of be in the area. So I ranked my transitional year and preliminary year programs. I tried to be in a totally different city.
This is only 1 year.
It's only 1 year. Okay. 1 year. And I wanted to be at a program where I felt there was a good camaraderie amongst residents. I did interview at programs where I didn't feel like people talked to each other or hung out. Okay. And if I was going to move somewhere different for a year, not know anyone, I would want there to be some type of camaraderie.
Right. Mm-hmm.
And then, the decisions of gut feeling, and I ended up ranking the same few top programs in my preliminary year with one of my good friends who went to med school with me.
Okay.
She's also a radiation oncology resident, but we ended up doing RTY year together.
Right.
And just kind of where, what city I want to be at. And she's in Chicago program is my top 3. And then I ended up matching in one of them. Okay. And then radiation oncology, my experience rotating was definitely very influential. I knew I was very comfortable in this program. And I ranked it, very highly. And I realized I wanted to preferably be in the area.
Right.
With that being said, in my top 5, I did place a couple places that were on the West Coast.
Okay.
And I had to be comfortable being like, hey, if I match there, I'll match there.
Yeah.
But I felt comfortable with that decision.
Okay. Yeah, I mean, I think, I've already said this, but for me, it was important to stay here. So both for my, transitional year or the intern year that we have before we do our actual programs, I wanted to be, in the area. And, so I did rank, the Philadelphia schools, higher than any other places, right? And the other places that came after, I made sure that, I was ranking them based on the fact that I had family in those cities. So Makes sense. Columbus was like, I have family in Columbus, right?
And you want support.
Right. And then Raleigh, Duke area, right? I have family there. So it's important that I rank that area. Baltimore area wasn't too far away from Philly, right? So if I'm not gonna end up in Philly, then Baltimore is like the next closest thing, right? So that was important. But I didn't want to live in New York City because I felt like it was too crowded, So I didn't rank them, as high because that wasn't the thing for me. So, essentially, the reason why we're talking about this is that you really have to think about where you're going to live for like 3 or 4 years, and then, sometimes as med students, before we get into these programs, all we are concerned about is matching, right? Like you want to match because nobody wants to not match and have to scramble for like a spot with some program that they don't want to be in, right? So yes, it makes sense that like people want to really be accepted anywhere, right? But you gotta think about where you want to live because it's so important. I just can't see myself doing residency in some totally like random place like that.
Yeah, those questions about life, like those really, like, where do you want to be? Where do you see? I mean, they become so important, and you don't even really think about those. I will also say sometimes it comes down to program. Like I ended up not ranking a couple places because I knew after my interviews with them, I was like, I just cannot go here.
Right. Yeah. So you get a sense of what the programs actually look like. So a lot of the programs will actually have like a night where you get to hang out with, the residents and like do dinner with them, right? And you get to know a lot about them, right? And their way of doing things, right? Even before you start your interview the next day. So you can kind of glean a lot from those experiences, right?
More than you think. More than you think, especially when you're at a dinner and the residents are really hating on their program a lot. Really puts you off of that program.
Right. It does happen. It does happen. So keep an eye out, keep an ear out, right? To kind of see and hear some of the things that like you can pick up when you're doing those aware rotations, when you're doing your interview trail, right? So that those are really important things that you need to pay attention to.
And sometimes it really just depends on where you can interview. If you don't get one, you can always reach out to them and tell them you're interested. So.
Right. So I guess like we maybe like winding down a little bit from this, episode. What was your, best rotation besides radiation? Don't tell me radiation oncology because I know you're a radiation oncologist. What was the other rotation?
Favorite rotation?
Right.
Pediatrics, actually.
Peds?
Yeah, I really enjoyed the rotation experience. Like and you'll see this when you go on rotations. There are some rotations that are like not structured.
Okay.
My Peds rotation was structured.
Okay.
Dr. Cass was incredible. Like she was amazing at really teaching, and I felt like I learned so much from her, just about pediatrics, but also in general about how to approach med school life and all these things. I felt like the people I worked with, the residents, were really cool, and they were nice, and they were just kind of fun to hang out with. They were helpful. You could approach them with any issues. I will say, I like kids, and honestly, I had a good time hanging out with the kids.
Okay.
As a med student, you're not the resident. You're not really the ones that, putting in the order and stuff.
Right.
So I had more flexibility to hang out with some of the kids. There was one, I'll remember this kid always. He was sick, he was kind of in and out. And we used to play like board games, and then we used to play like Nintendo DS. And I mean, that was kind of fun. It was just me hanging out, but it was fun to hang out with him. It was fun. I really enjoyed that experience.
Right.
I would say Peds was probably my favorite rotation. And one of the other things, I mean, they had like a Halloween party thing, and we would all have trick or treats.
You had a lot of fun on Peds.
Dude, Peds was a lot of fun.
Yeah,
I had a good time.
Yeah.
How about you?
I think I was probably the most fascinated with transplant.
That's fair.
I just remember like just going to another hospital to kind of like get an organ, right? Like that feeling of like going to talk to a family of I wasn't doing the talking, obviously, right? To kind of like talk to them and like thanking them for like donating, right? An organ, and also being in the operating room and seeing how you do, organ transplantation, right? And like, it's just remarkable because you're giving this person a new lease on life, right? Where you're taking this organ from another individual and then placing it in another person, and it's working. Like it's like you can see, like, especially with kidney, right? Them recover from the surgery and then seeing how their lives were before and how they felt, and now they're doing so much better, right? I think transplant was like the really, really fascinating. Maybe the biggest one was like seeing a liver. I saw only like 2 liver transplant, and it was just like, oh my god, that's a whole lot that goes into like transplanting a liver. And just seeing someone who like was jaundice, in end stage liver disease, right? And then slowly like doing better and like, recovering from that after they've gone through all the process of transplant, right? And seeing some of them in follow up, right? And like looking at how they were before and like and how they're doing after, in follow up. It's just like it was so remarkable. Obviously it was surgery and it wasn't oncology, so it wasn't, there's a whole lot of things about transplant that I definitely didn't want to deal with, but I thought like just getting an organ transplanting and just like, that organ starting to work in another individual was just remarkable.
Yeah. I will say I did see a lung transplant. That was really cool.
Right.
That was fascinating.
Right.
Really. Oh, I'll also put a plug in for. I spent. It was only a few days in the palliative medicine team. It was. I knew that. I mean, I will never be a palliative medicine doctor, but I also really respected them a lot. It was a really tough, gig.
Yeah.
And like we do, stuff like that. We work with them.
Yeah, we work a lot with palliative. I mean, there's a lot of ways that like even radons can be palliative docs, right?
Yeah. But I think this was, I guess what I mean is a lot of the end of life discussions, which, I'm not like looking forward to them. I really respect the palliative doctors a lot.
Right. Those are some heavy stuff. Those are the times where I wear my white coat. Yeah, because it's just you gotta come in with everything, right? You gotta come in with everything, and this is a really difficult conversation. And I think that's the time where like you can totally be honest with like a patient, right? Like just telling a patient that we think you're dying, and we don't think we should be doing anything more for you because we will be doing you more harm than good, right? I think that's a difficult thing. It's like we all know it, the patient knows it, but until the doctor says I think we have to stop. Yeah, it doesn't really sink in, and you don't really accept that reality. And a lot of the time, before you do have that conversation, a lot of the patients know. And the times that they don't know, sometimes they get angry, like family members get angry. What are you saying? And then like, you sit with them for a little bit and then they start, really coming around to it. I think that is heavy. I don't know if I would put that as my best rotation.
My best rotation.
All right. But
was there the most surprising rotation? Like, was there a rotation you found the most surprising?
Yeah, I just didn't realize how much people who are in labor poop.
Oh yeah.
I don't know, for some reason I didn't think of
excretion of liquids.
Like literally pooping. Like I was like, and we're all standing there, delivering, and it's like, my god, yeah.
So you don't think about it, but it makes sense.
Yeah, it makes sense. They're like they're exerting themselves, right? They put bearing down on the abdominal muscles and all that kind of stuff. I just never really thought about it. It was just like it's funny thinking about it, but like it's just like, oh yeah. What about you?
My inpatient psych was really interesting. My day 2, some guy tried to escape the ward, and my attending I was working with saw him, started running after him.
Okay.
And like tried to pin him against the wall.
Really?
Yeah, dude. And then they call security or whatever, but they weren't there at that second. Pin against the wall. The guy turns around, punches my attending in the face.
Oh, really?
Yeah, man. And I was like, dude, is this psycho? Like, is this what I'm expected to do? Yeah, that was definitely an experience.
Hopefully, you didn't have to tackle anyone down, right?
I did not. I think they really pushed against the idea of students trying to tackle anyone. So
yeah, yeah, that's.
But I was like, wow.
That was your first day too?
It was like day 2.
Oh, okay.
Also, there were just some interesting patients.
Wow.
You see some interesting stuff on site.
Right.
Sure.
Oh yeah, for sure. I mean, I did see some interest. Not tackling someone like that's.
Yeah.
Oh my god.
I will never forget. Like clocked right here in the cheek, man.
Yeah.
Right there.
All right. Well, I feel like this is a really good conversation on medical school, and there's a lot that goes through making the decision of what you're going to do in med school, and some of it will just come naturally. So I think that the overarching theme here is that like you really need to understand what you want and what you don't also like in a specialty, so that you're not spending so much time trying to like weed out things, right? Like I feel like your time probably is better spent like narrowing things down sooner if you can. But I guess a part of the experience is also going through the process and building some character too, right? Out of all of that, I certainly wouldn't want to go through the route of like going to ENT, urology, and all that kind of stuff, and before coming to the conclusion that I like, radiation oncology. I think it will probably be a smoother transition to just kind of like think about these things sooner than maybe later, than maybe 4th year, right? Like you don't want to do that.
Yeah, it would have been much easier on basically your whole life if you could decide earlier.
Right.
But that is all we have for today. Thank you for joining us. If you're a med student, or even if you're a resident or attending, and you have your own stories you want to share, feel free to reach out.
Yeah.
Any of the ways in the show notes below. Next episode, we're going to talk all about relationships and dating and medicine. So hope you join us then.
Bye.
See ya.